Hello, good evening. Welcome to my IVF-ICSI and the European Fertility Society. We are back once again to educate you, to answer your questions. And of course, today's topic is how age impacts equality. So we have our special guest who will discuss this particular topic. You can see her right here. Dr. Marina Diaz is with us. So I'm really excited to have you. This is your first webinar with my IVF-ICSI, so I'm really happy to have you. Dr. Marina is the fertility specialist, gynecologist at Clinica Tambre, and we had many doctors joining from Clinica Tambre. So I'm really happy that you are also one of them as well. Hello, how are you? Hope you had a good and busy day, huh?
Thank you very much. And thank you very much for having me here today. It's been a very good day and it will end up equally good after this webinar. So I'm very happy to be joining this and to be able to give my insight into this as well. And obviously
Brilliant.
answer any questions that may pop up.
Definitely, of course. So, as you know, we will first start with the presentation. Afterwards, there will be time for your questions. You can put the questions in the chat, and Dr. Diaz will answer them for you right after her presentation. So you can type them during the presentation or afterwards, of course. And remember, this is anonymous. It's a safe space for you. So feel free to ask anything that's on your mind. And of course, the event is also recorded. So if you need to leave, hopefully not, but if you do, you will have a chance to rewatch this. It will be available on our website. And before we actually go to our presentation, a few words that I would like to introduce. As you probably perhaps already heard, the European Fertility Society has created the first European certification, which is actually called, as you can see, the Patient-Centered Care Clinic Program. And this aim of the certification is just simply to help you identify clinics that truly put patients first. So in every part of the fertility journey, as we know, it's definitely tough. And sometimes because of that certification, you can simply have a look at the clinic who already actually had gone through the process, because it's not easy to actually receive this kind of certification. And you are able to find out a little bit more on that on our website, My IVF-ICSI, and clinics who have received the certification. You will be able to see which ones are those. And that's just my short intro. But of course, now I think we can go ahead with our topic. So, Dr. Diaz, are you ready?
I'm ready.
Happy
Okay.
to hear that. Let's go.
So good afternoon. As I've already been introduced, I am Dr. Marina Diaz, a specialist in gynecology and fertility working at Clinica Tambre. And today's topic is going to be about how age impacts egg and therefore IVF success. These are the bullet points that we will be covering today. The relation between age and fertility, two concepts, ovarian reserve and egg quality, the impact of age on IVF outcomes, what are the available treatment options, and we will end up by a slide commenting the conclusions. Some of you might have already seen or might already be familiar with this graph here. This is the way maternal age relates positively to aneuploidy rates and miscarriage rates, and how it relates negatively to the percentage of live birth. So basically, this means that as women age, the rate of miscarriages is going to increase at the same time as the percentage or rate of live births are going to decrease. Therefore, female fertility is closely linked to time and, most importantly, to age. The reason is because every woman is going to be born with a certain number of eggs, and the moment we start with our periods, we're going to be depleting ourselves from these eggs, and the quality of them is also going to start decreasing. And this event happens more abruptly as we turn 35. And I would like to clarify that it is not the moment you turn 35 that things are going to go down the hill. But it's true that it is sort of like the time in which we see that gradually things start to speed up. And the way we see this, or the way it translates in IVF treatments, is by increasing the chromosomal abnormalities within embryos, meaning aneuploidy rates. And also, we will see that women are going to start having more difficulties conceiving naturally. The percentage or the probability of actually becoming pregnant naturally in a cycle is going to decrease over time. So at the age of 18, it's going to be around 25-30% chances of becoming pregnant naturally. And in women over 38, this percentage, this probability is going to decrease significantly, and it could even be up to only 3% per cycle. And that is how we see the way age is going to impact our fertility. As I said, and I mentioned before, a concept that's the aneuploidy rate or the aneuploid embryos. I'm not sure whether I'm assuming that you know what it is. An aneuploid embryo is an embryo that has an erratic number of chromosomes within their genetic material. So normally we should all have a certain number of chromosomes. As we age, our eggs are going to accumulate some errors in these chromosomes, and therefore the moment they're fertilized, they will give us embryos that are not going to be genetically viable because they won't have the correct number of chromosomes. So as we age, the aneuploid embryos are going to increase, and we'll see that the miscarriage rate is going to increase as well, and therefore the implantation rate is going to decrease. Now, we've talked about aneuploidy rate statistics. Let's focus on ovarian reserve. What is the concept? What do we understand by ovarian reserve? It refers to the number of eggs available in the ovary at a specific moment in life. And we can either assess it through an ultrasound scan, counting the number of follicles, or through a hormone called AMH, antimullerian, which is, on the other hand, much more reliable. This AMH is secreted by antral follicles, okay, and it's pretty much stable throughout the whole cycle. And that's why it's more accurate and it's more reliable than the antral follicle count, because the antral follicle count can vary from one cycle to another one, whereas the AMH is going to be much more stable. And this AMH tells us more or less what our ovarian reserve is. We consider a low ovarian reserve anything below 1 nanogram per milliliter. A normal ovarian reserve would be between 1 and 3.5, and a high ovarian reserve, it's between anything above 3.5. What are the things, or what are the parameters that can negatively affect the ovarian reserve? The most important one is age. As we age, our ovarian reserve is going to deplete, it's going to decrease. And in fact, when women become menopausal, that means that they no longer have eggs, okay? Other things such as gynecological pathology can also affect negatively the ovarian reserve. Endometriosis, benign cysts, they can affect negatively the ovarian reserve. Any ovarian surgery, for instance, women having a cyst that has to be removed, even if it's benign, you could accidentally damage some of the healthy parenchyma, decreasing the ovarian reserve. Family history of early menopause or premature ovarian failure linked to some specific diseases can also affect the ovarian reserve. Cancer treatments and even toxic substances that some patients, women might use, such as smoking, cigarettes, etc. When it comes to the ovarian reserve, as I said, women, we're normally born with a certain number of eggs, and this number of eggs is going to remain the same up until the moment we start having our periods. As we start having our periods, in each cycle, our body is going to release a certain number of eggs. By the time we reach the menopause, okay, that's when we will deplete ourselves from these eggs, and that's when we become menopausal. Okay. Now, we've discussed about egg quantity, AMH, antral follicle count, how this is related to age. The other very important parameter, and that is going to be a very important factor determining the outcome of an IVF cycle, is the egg quality. The quality refers to the genetic and functional state of an egg. And unfortunately, we do not have any parameters or any tangible parameters such as the AMH to assess an egg quality. We know that it's more linked to women's age. It's the main factor. Women's age is the main factor that is going to affect the egg quality. And again, it's key to the success and the outcomes in IVF. Again, this chart, this graph in which we see how as we age, there's going to be a higher rate of aneuploid embryos. The higher the rate the aneuploid embryos, the higher the chances of having a miscarriage and the higher the chance of an embryo not implanting. When we have an aneuploid embryo, the majority of the times, this embryo is not going to implant. Sometimes it does implant, but your body recognizes it as an abnormal embryo, and that's when early miscarriages happen, okay? And that's why women above the age of 35 have a higher chance of having a miscarriage, okay? The AMH is going to decrease over time. The ovarian reserve is going to be decreased over time. The antral follicle count is going to decrease over time, and the egg quality is going to increase over time. So everything tends to decrease over time, except for a hormone called FSH, which is going to start increasing over time. And that's just something that I find curious. So, as I said, age is going to have an impact on IVF outcomes. And as we can see, the older we become, the lower the chances of a treatment being successful. In women under 35, you can have success rates of around 70%. And as you can see, this is going to significantly decrease as we reach 40 years old. Over the age of 40, I'd say over the age of 42, the chances of becoming pregnant with our own eggs is going to be reduced by quite a lot. Having said this and facing this problem or this problematic in which age and how age affects an IVF outcome, what are the options? What can we do to mitigate the effect of age in our family project and IVF outcomes? We can either say, okay, I know that at some point I want to have a family. Maybe right now I'm not at the stage of having this family. Why not egg freezing, fertility preservation? For those women that are already there who want to have a child with a partner, we can just go directly into IVF-ICSI, testing the embryos, always being realistic. And if there's already been an unsuccessful treatment with our own eggs, we can always opt for egg donation, double donation, or even embryo adoption. So that, as you can see, there are different options, which we will discuss more in depth now. And each treatment has to be adapted to each personal situation. So it's not the same a woman willing to become pregnant in the future as opposed to a woman who's trying to conceive right now, as opposed to a woman who's already done several IVF treatments. So we've got to adapt ourselves to each couple's situation. When we talk about egg freezing, who would we recommend it to? The majority of the times, women who come over to freeze their eggs is because, again, for social reasons. I know at some point I want to become a mother. Right now, I don't have the ideal situation, but I want to prevent myself from the age impacting my situation in the future. So that's the majority of the times why patients freeze the eggs. But there are other reasons as to why somebody might be interested in freezing their eggs. Maybe they are going to undergo an ovarian surgery. As I said, when you do a surgery in the ovaries, you could accidentally touch or damage some healthy parenchyma. So some patients, knowing this information, they decide to first go an egg freezing treatment and then undergo the surgery. Other patients might have to freeze their eggs because they're going to have to undergo chemotherapy. So as you can see, there are different options, although it's true that the most common one is women willing to preserve their fertility because they're not in the ideal situation, but would like to become or have a family in the future. When it comes to couples wanting to become parents at this time, normally the first option is to go for IVF, especially if they're between 35, 40 years old. And more specifically, we tend to do ICSI, which is taking the spermatozoid and injecting it directly into the egg just to prevent any fertilization failures and so on. And the idea is that we're going to be stimulating a woman to retrieve as many eggs as possible. We will retrieve those eggs, we will fertilize them with the sperm, and we leave them grow for 5 days in an incubator until embryos reach the blastocyst stage. And depending on each type of couple, the background, we might do a fresh embryo transfer, we might test the embryo. So there are different options, and it's all about personalizing each treatment. It's true that given that we're speaking and talking, discussing about age, normally when women over 35 do an IVF treatment, they normally at the stage of the blastocyst, they do a biopsy on these embryos to make sure that in the future we will only be transferring embryos that have the correct number of chromosomes, and that's what we call PGTA. For what are the success rates of IVF? As I said, it depends. IVF with our own eggs, it depends on women's age. The younger we are when we start all of this process, the higher the chances of becoming pregnant. As you can see, it significantly decreases as we age. Over the age of 39, the success rates can drop up to 42%. If we take into consideration women who are over 43, the percentage will be significantly lower. Okay. And for those patients in which they've already tried an IVF treatment, has not been successful, or are already a certain age and know that the success rate with their own eggs is going to be limited, for those women, we have egg donation as an extremely good option with extremely high success rates. For those women who are also menopausal, that's also an option. So I'd say, like, to summarize the main indications, medical indications in which I'd recommend an egg donation treatment would be women with a premature ovarian failure or menopause, in which we just don't have any eggs to stimulate or to fertilize. For those women that have already done several IVF treatments and that have not been successful. For those women with a low quality egg or quantity of eggs, okay? Obviously those who might have genetic diseases that want to be, and they want to avoid transmitting them to the offspring, and women who unfortunately have undergone chemotherapy and no longer have functional ovaries. With egg donation, as you can see, the success rates are extremely high, okay? Because we're overcoming the limitation of egg quality, egg quantity. By the third embryo transfer, the majority of patients, 91% of our patients, will become pregnant, okay? And that's something that we do have to bear in mind when looking at our options. Some patients, especially for single women or couples in which they're both a male factor or a female factor, they might decide to go for an embryo adoption. This means taking one of the embryos that we have in our bank and transferring one of those. It's an embryo that has already been created and in which the success rates are also very high. Okay, so this would be especially for couples of women that do not want to do a double donation, that would rather just adopt an embryo that has already been created and transfer that one. Okay, so as I said, women without a partner who prefer this treatment to intrauterine inseminations, or a double donation for female couples who, as an alternative to the Roper technique, for heterosexual couples diagnosed with a mixed infertility, so whether female gamete and the male gamete is affected, and also for women with low ovarian reserve due to seeking pregnancy at an advanced maternal age. And as I said, the success rate is actually really good, between 50-55% of success with an embryo, with embryo adoption. And for those who prefer to go for a double donation, so the same indications as for the embryo adoption, but for those who would rather create all the embryos from an egg donor and a sperm donor, mitigating the effect of what a male factor could have in terms of results. We've got the double donation, and this is recommended when the ovarian reserve is very low for single women having to use a sperm donor, for patients that have already undergone several treatments with egg donor and the partner sperm and that still have not become pregnant. Sometimes by changing this into a sperm donor, we can have higher success rates. As I said, this treatment has a very high success rate because we're taking donors that are by the book. They're young, the majority of the times, a proven fertility, who are already here because we've already ticked certain boxes, and therefore it's just the best type of embryo that we will achieve eventually. Okay, so a very good treatment option. Up until now, I've discussed all about egg quality, egg quantity, different options. Now, what can we offer from Tambre? What's the Tambre experience? I believe this pretty much sums up how I would describe ourselves. We do combine science and humanity. Each couple is individually looked after. We do personalized treatment. We listen to patients. We acknowledge what they need, and I believe that's extremely important whenever we embark a fertility treatment. The environment in which we work is very friendly and patient focused. We personalize each care. There are different doctors speaking different languages to make things easier to overcome communication barriers. And of course, we are always on top of the research with very up-to-date equipment, techniques, and professionals. As I said, we would end up this presentation with a slide regarding conclusions. And I'd say these 4 bullet points are the takeaway message. Age does influence quantity and quantity of eggs, and this is something women and generally couples should be aware about. We cannot increase the quality of our eggs or generate new ones, unfortunately. Every woman is unique, and therefore every treatment should be unique. And there are always alternatives to fulfill the desire of motherhood, meaning that we all prefer to do an IVF treatment with our own eggs, but there are different options that will lead you equally to becoming a mother or a father. And I think all of these have to be put into balance to select what suits you best in the specific moment in your life. Okay, so thank you very much. I think this is all from my side. Now, I'd like to hear from you any questions that you may have, and yeah, any discussions that you'd like to open. This is a woman who's 40 years old with a good AMH, I must say, who's already conceived naturally in the past. So also a good standing point. And who's trying to conceive and looking for baby number 3. She's already had seven early miscarriages and has been diagnosed with antiphospholipid syndrome. Therefore, she's on Clexane, Plaquenil, aspirin. The sperm quality is okay. DNA fragmentation is 21. Bloods are normal, no other known issues other than low lactobacillus treated with probiotics. So you've also done an Emma Alice test, suspected adenomyosis and recent ultrasound. Okay. So, and now there's some questions about how to proceed or what I do. So, as I said, first thing, the fact that you've already had 2 pregnancies with a live birth, with 2 live births, that's already a good starting point. This means that your uterus is completely capable of becoming pregnant and of carrying a pregnancy. Regarding the miscarriages, there are several investigations that you can that we can investigate, but I think the priority number 1 at this stage, if undergoing an IVF treatment, would be to test the embryos, do a PGTA test on the embryos to make sure that whatever we're transferring is a viable euploid embryo. The way I always put it down is that the majority of the times, especially if a woman has already had children in the past, the majority of the times when there are miscarriages, when we have implantation failures, it's mostly due to the fact that the embryos are not genetically viable. Okay, so the first thing that I do is to make sure that we're transferring viable embryos, and that way we're already confirming that in the most important thing is okay. There are other investigations, okay? You've already done the antiphospholipid syndrome and you're treating it accordingly. You've already done the Emma Alice. You do have a history of adenomyosis, in which case that could be an area that could be targeted through down regulators prior to an embryo transfer, okay? Because sometimes adenomyosis, at least the moderate to severe one, can reduce the implantation rates and can increase the miscarriage rate. So that's something that I think should be considered and taken into account. And those, I think those would be the things that I would focus on. The most important one, the PGTA testing. Then there is a very grey area regarding immunological testing in women trying to conceive with miscarriages. At this stage, I would probably not go down that route because I think there are other things that we can prioritize first. I don't think at this stage I would recommend a laparoscopy. I don't think that's the way to evaluate this case. I think age has had an impact over this time, and probably the embryos that have been transferred or that you've been becoming pregnant with weren't genetically viable.
Brilliant. Thank you so much, Jenny, for your message, and of course, Dr. Diaz for explaining. If there are any other things you would like to ask, of course, you can still do it. Of course, you can go ahead and type this in the chat. But in the meantime, we can move on to the next question from Sarah. This time, I'm 45, still ovulate and get a period each month. My partner and I did many IVFs that all yield embryos. However, 1 miscarriage and no baby. Some clinics promise very high success rates for women of my age with their own eggs, around 45%. Are they putting numbers to get customers? What about MTR? Not sure. Is that a viable option or is it too experimental to tell? I think it's about the mitochondrial donation, perhaps.
Yeah. So, okay. As I said, age is extremely important in terms of IVF outcomes. At the age of 45, the success rates with our own eggs is less than 3%. Okay, because it's difficult to achieve creating or having euploid embryos. Okay, so I would not recommend a woman who's over the age of 43 to do a treatment with their own eggs, even if they have a high ovarian reserve. the number of eggs that you will need at that age to create one viable embryo, it's very high. Even if you still ovulate, that means that yes, indeed, you can become pregnant because you're still releasing eggs, but most likely you'll have to undergo a lot of IVF treatments, a lot of stimulations to get one healthy embryo. And obviously at that stage you have to balance, and that it's not even a guarantee. To me, a success rate of 45% at the age of 45, to me it sounds a bit unrealistic. Okay, my general advice when I have women with these circumstances is to opt for egg donation or double donation, depending on their personal situation. Just because realistically speaking, it's going to have much higher success rates. It's different. Some women would like to at least try or give it a try, but it's true that they have to have the whole information and the whole picture. You can try as many rounds as you want, but it's not going to be the most efficient treatment. When it comes to mitochondrial transplant and so on, that's still something that's extremely, extremely experimental, and that the majority of clinics do not do. And we don't really have proper results to give information accordingly. So I don't think at this stage, on the 8th of September 2025, I do not think that would be the route to go.
Course, thank you so much. Only some clinics, some countries even allow it. So that's something that you need to remember. We did some events on that, but you can check them on our website. However, keep in mind that, as Dr. Diaz said, it's still experimental. So it's important to know that. Okay, thank you so much indeed. Hope that was useful. Let's have a look. Okay, we have another question. Keep them coming. The question is here. I'm 38. I have already done 6 egg retrievals in the last 3 years, each giving about 7 mature eggs that resulted in a total of 6 untested blastocysts. My doctor told me that chances of me getting pregnant are in 2.25% level. My PGT application was denied. All blood tests, hysteroscopy, HSG, ultrasounds are all fine. Is there any hope that I can improve egg quality? I'm already taking CoQ10, prenatal vitamins, and inositol. Don't drink and don't smoke. Anything you can advise? I'm sure you're hearing about supplements, etc.
So it's true that you started this 3 years ago with 6 blastocysts. Statistically speaking, you should have at least have 1 or 2 embryos being genetically viable. Okay. So that's something to take into account. It's true that without having tested the embryos, we won't be 100% sure. So moving forward, if you do decide to undergo another treatment with your own eggs, that's something that I would definitely consider. Make sure to test your embryos. And again, this is not because it's going to increase your chances per cycle. It's just to make sure that we're transferring the embryos with a higher success rate. Okay. And once we're sure that this part of the treatment is correct, then we can start investigating other things. From what I've read, you've already done all of the investigations. When we have these type of circumstances, it is true that at some point we normally offer or explain the option of changing at least one of the gametes. And the gamete that is normally changed, because it has a greater impact, is the egg. Unfortunately, as I said, we do not have any tools to assess the metabolic quality of an embryo. You could have an embryo that is genetically normal, but metabolically might not be normal, okay, or might not be the best. And we don't have the technology nowadays to test for that. Do we have any supplements or anything that we can do to improve the quality? Unfortunately, and I believe that's what I said in my last slide, is that nowadays we don't have anything that has proven to increase significantly the egg quality or the ovarian reserve. All of the supplements that have been released, they're not going to damage. If anything, they could be beneficial, But the truth is that there's no evidence as to how much benefit they can offer. Okay. And I wouldn't, the message that I like transmitting is that for those women that are in that situation which they do not know what to do, don't rely on these supplements to keep on postponing making a decision, because most likely there won't be that much of an effect of these supplements on the egg quality and egg quantity.
All right. Thank you so much. Again, that's another topic we could discuss for hours, I'm sure. There are always questions on that, of course. Thanks a lot. And now let's have a look at the next question. I'm just looking if we have any follow-ups, but there's a thank you from our patient here. And let me just go to the next question. Quite long questions. Thanks a lot for those. After 2 failed IVFs, ovulating. I'm not sure here. Embryo to blastocyst. Okay. Stage out of 15 embryos around age 40, but no apparent uterine issue. I consider egg donation. What is the rush in making that decision? Meaning how age between 41 and 45 would affect the pregnancy rate and birth of a healthy baby? As I believe this is called geriatric pregnancy. Thank you so much for your question.
Okay. Two IVF cycles without having made it to the blastocyst stage and is willing now to switch on to egg donation. There's no real rush, okay? The truth is that as we age, women are going to be more prone to having complications throughout pregnancy. And that's true. So it's not the same having a child at the age of 40 as opposed to having a child at the age of 30. At the age of 40, you are more at risk of developing complications such as preeclampsia, diabetes, having a C-section, okay? But in terms of the implantation rates and the miscarriage rate and so on, when using donor eggs, age does not matter that much. It's true that in women over the age of 45, there is a slight increase in miscarriage rate, but it's not truly significant. So I'd say there's no real rush in terms of IVF outcomes. It's just that obviously, the older we become, the higher the chances of developing complications throughout pregnancy. So I guess my advice, if you've already decided or made the decision to switch to egg donation, I'd say the sooner the better, because you're going to have a more patient-friendly pregnancy, most likely. Okay. So that would be my advice. And I think there was something else, but I cannot remember.
Yeah, let me just share it once again.
Endometriosis and adenomyosis.
Sorry.
The truth with endometriosis and adenomyosis is that we know that severe adenomyosis, severe endometriosis can affect the implantation rates and the egg quality. When it comes to light adenomyosis, mild endometriosis, there's no real evidence as to how much that can affect, okay? Because in the end, as we age, the majority of women were going to end up developing some adenomyosis. And the fact is that women who are doing egg donation become pregnant very easily as well. So again, with mild, I'm not too concerned about it.
Okay. All right. Thank you so much. I think that was it. Sorry about it. I confused the questions, but let me just go to this actually question. Again, it was about mitochondrial donation, but let me just show it to you. Sorry, it's just lots of questions that I need to look through. Yeah, from Vivian, I think we missed that. Looking at the mitochondrial donation, do you think I would be a good candidate? You already mentioned that, but let's have a look at the second part. I'm 44, high MH, getting harvested up to 15 eggs at a time, usually get average 2 blastocysts. With PGTA normal results, implantation occurs, but immune system attacks embryo. Would a stronger mitochondria with the eggs be something I should consider before going for embryo donation? Anything you can advise here?
First of all, I'd say that you're getting very good results with your IVF treatments, having had 2 euploid embryos, it's a very good result. Okay, and the fact that implantation occurs, and that's also very positive. Regarding the mitochondrial, again, all of the evidence or research about that is still extremely experimental. Okay, so I don't think today I would go down that route. If anything, I'd start by addressing all of the immunological disorders and potentially seeing an immunologist rather than going for mitochondrial transplantation donation. I think that is going to be more realistic, and that if we target those areas, the outcome could improve significantly. With
That
mitochondria,
makes
again,
sense.
it's
Yeah.
very experimental nowadays.
Okay, sorry, there's a follow-up from Vivian. That's why I
Yeah.
wanted you to see. I've had transfers, failed implantation, 4 miscarriages, now all PGT and normal. I have changed the sperm donor, done ERA-EMA test, got the environment optimum. Anything else?
So at this stage, I would advise to address those immunological disorders by seeing an immunologist who specializes in in fertility. Okay. The other option, as I said, mitochondrial, very experimental. The other option would be to see if by changing the other gametes, so egg donation, you'd have a different outcome.
All right. I hope that was even helpful. Let us know if there's anything else you wish to add, obviously. So we have another question here. So I'm 39, had 2 retrievals, got 1 mosaic, low level, and 1 euploid. My euploid resulted positive. Unfortunately, the healthy pregnancy ended due to incompetent cervix in 2nd trimester. Did another retrieval after loss, 13 eggs retrieved, no euploid to transfer. Instead of long suppression Lupron protocol, my doctor is telling me to try low dose Lupron flare-up protocol. I have an endometriosis, and I'm not sure if we have the second part. Let me see, but we can still answer.
Yeah.
I guess. Yeah.
Well, first of all, it was extremely unfortunate that you lost your baby, and it ended. The good thing is that you still have a mosaic embryo. So in terms of the protocol, I think there's not much difference in terms of outcomes depending on the protocols. Okay.
There's more, my equality is not very high, I'm 39, right? So this is, my doctor wants to go from flare-up protocol with 400, gonna left, no menopause. So what are your thoughts on
so
this?
as I said, regarding the protocols, there's no evidence that one might be better than the other one. Okay. In my particular case, I have had good success rates with either long protocols and short flare-up protocols. Okay. It is true that one of the things that I do think, especially in women over 35, when using gonadotropins, I normally do prefer using gonadotropins that have LH activity. So in your case, Gonal has only got FSH. So I would probably add some menopur or another type of medication that includes both FSH and LH activity. So that is something that I would take into account when deciding which gonadotropin to use. Regarding the protocol, I think both protocols could work equally well. Even a short protocol or a luteal phase stimulation, I think in terms of protocols, they could all have more or less the same results, or at least in terms of live birth, none of them have proven to be better than the other one. It's true that long protocols can increase maybe the number of eggs, okay? But on the other hand, there's a higher risk of having a hyperstimulation syndrome. Regarding the protocol and the endometriosis, again, none of them has proven to worsen the endometriosis or improve it. if that answers your. So I think using a short flare-up protocol, a good option. Most likely you'll get a good number of eggs. The only thing that I would change is not using gonadotropin with LH activity.
Okay. Thank you. Indeed, I hope that was useful. Again, thank you so much, Dr. Diaz, for answering those questions. And of course, we have some more time, so go ahead, type those in. We definitely want to help as much as possible. We have around 10 minutes, so don't hesitate. Let's have a look at the next question that we've got here. A short one, this time. What are the odds of success at 40 plus with egg donation versus egg donation with surrogacy?
Okay, so this is a complex question just because in Spain, we don't have surrogacy is not allowed, so we don't have our own data. Okay, but I guess if I were to answer to that question, I'd say if we're changing, it would depend on the characteristics of the surrogate. Okay, so in terms, it's not the same. Let's say the same embryo, if we put it back in a woman that has undergone or that has infertility, who might have adenomyosis, endometriosis, or unknown infertility, then my gut feeling would be that potentially that same embryo in a womb with perfect conditions might have a higher success rate. But again, we do not have our own data, so I wouldn't be able to give you specific percentages on that, unfortunately. I'm sorry.
That makes sense, of course. Thank you so much. Thank you indeed. Just let me see, because okay, there's a thumbs up. Thank you for answering. And as I've mentioned, we still have a few minutes. So if you want to type any questions, go ahead. In the meantime, I know that we also receive lots of questions in regards to mini IVF. Can you tell us who is a good candidate for a mini IVF?
So mini IVF understood by low dosage medication when stimulating. So I normally say that when doing an IVF treatment, you're trying to retrieve as many eggs as possible. Now, the number of eggs that we're going to be able to retrieve depends on a woman's AMH. So I'd say that a mini IVF would be a very good option for women who might not have a very high ovarian reserve, and in which either giving 300 units or 150 units every other day will end up resulting in the same numbers. I'd say that to me, that's the best. That's the best candidate that I would offer mini IVF to.
Thank you so much indeed. As I mentioned, we do receive lots of questions on that, so that's why I wanted to check this with you as well. And we already also discussed this. I'm sure you see the question: how can we improve equality? You already mentioned this. This is not easy. We don't like, I would say, the answers to it because there's no miracle drug, let's say, right?
That's the thing, and if the moment somebody finds out or gets to see something that could improve egg quality, they would have sorted so many problems regarding infertility and so on. But unfortunately, nowadays, as per today, there aren't any treatments that will improve the egg quality. Obviously, lifestyle, the healthier you are, the better your eggs are going to age, and you can sort of like decrease the speed at which egg quality is going to decrease. For instance, a woman that smokes, the ovarian reserve and the egg quality is going to decrease faster than a woman that doesn't smoke. A woman that has a healthy diet is going to age better in terms of egg quality and so on than a woman that has a very erratic or chaotic diet. So all of those things are going to maybe not improve, but help with the lower speed at which egg quality decreases.
So we can just try our best to have a healthy diet, etc. This is the best thing to how to proceed, I guess, right? Thank you so much. All right, I think one more question is here. So let me show you. And this might be our final question, but if you have any more, you know what to do. The question is, so any further investigation recommended before proceeding to PGTA IVF? All conceptions have been unassisted, to date. Hysteroscopy, in lieu of laparoscopy, perhaps anything else. This is from Jenny, our previous patient, yeah?
Okay, and let me just confirm something.
Yeah, sure.
Obviously, okay, yeah. So, yeah. Okay. So prior to, I thought you had already made your mind about doing an IVF treatment. So things that can be investigated when having recurrent miscarriages. And again, I do want to insist that the majority of the times it's related to the embryo itself. But other investigations that can be done are a 3D scan to make sure that there are no abnormalities within the endometrium that could be affecting the implantation rates. Then a matter of also assessing through a hysteroscopy, see if there are no signs of chronic endometriosis, doing a biopsy of the endometrium to check whether there are any abnormalities as well that could be treated. So there are investigations, but always knowing that the most important thing is the embryo.
All right. Thanks a lot again for that. Jenny, if there's anything else, you know what to do. Vivian would like to ask you about the immune system investigations. Do you do it at Tambre? How does it work?
We've got our
Do
own
you specialize it
immunologist.
at this as well, right? This is the question.
We do have our, sorry, I interrupted you. I'm very sorry.
Sorry, do you specialize in this as well, right?
Yeah. We've got a specialist. So we normally ask for the blood test and we work together alongside with an immunologist, and normally patients are referred to the immunologist, and he would be the one optimizing the treatment plan and giving further instructions if needed.
Okay. Someone is typing, so let's give it a second. Let's see, because there are some thank yous. So yeah, thank you so much for your advice. As you can see, the comments are coming in. So I guess we will be finishing for today, but thank you everyone for joining us. This was very interesting, full-on questions. Presentation was definitely detailed. So as I mentioned, there are many topics in this one topic that we could discuss. So thank you a lot, everyone. And Dr. Diaz, thank you so much. This is your first event. We're really happy to have you. I hope you also are satisfied with how everything went. I think we got lots of questions as well, which is always great. That means that we are here and we can help. So I guess that's always nice. Any final thoughts? Anything you would like to add?
Well, I think that the main message is that obviously you still have to stay positive. There are different options, and you know, you have to seek for advice and trust the process and trust that we from the other side are always going to try and help you and to make your dream family project come true. So yes, just rely on the doctor. We're always going to try and do the best for you, and so that everyone reaches the end point, which in the end is becoming parents.
Thank you so much indeed. I think that was on point. Nothing else to really add. So thanks everyone. I just want to add only that tomorrow we will be live at 7 p.m. We will discuss mosaic embryos. We will discuss about low-level mosaic embryos, but also high-level mosaic embryos. There will be 2 speakers with us tomorrow. So go to my IVF-ICSI and you can simply see all of our upcoming events. So stay tuned. I'm really happy that we are able to discuss this today. Thanks everyone. You can see the thank yous in the chat, I'm sure, Dr. Diaz. And have a lovely evening, everyone. Take care and hope to see you here quite soon. And I'm sure you will have more questions. Thank you. Bye.
Thank you very much. And thank you everyone for attending.
Thanks. Bye.
Bye-bye.